Thank you. So for those who may be just joining, my name is Sarah Rios. I'm an assistant director with the Clinical Research Finance Office, and I am here with Scott.
And I'm Scott Kennedy, another assistant director with the Clinical Research Finance Office. And yeah, I'll hand it off to Sarah to go ahead and get get started.
All right. So we're going to be taking a look at the CRFO and how it supports research here at UI Health. So at the end of the presentation, we hope that you will be able to describe the mission and role of the CRFO in human subject research, the rationale for building your studies in EPIC, understand the principles of research billing compliance, and recognize CRFO ancillary reviews in UIC research and how they impact IRB approval. Next slide. Our agenda for today will take an intro to the CRFO, general information, then we'll move on to research billing compliance and principal investigator responsibilities with that. Then we'll look at the CRFO's interaction with IRB and OSP, including we're going to take a look at the new research fee schedule, which is effective September 1st for new studies. We'll then look at how you can request EPIC research training, and finally, the UI Health research policies. Next slide. So our introduction to the Clinical Research Finance Office. We are a compliant clinical research billing program administered by UI hospital and clinics in coordination with the OVCR. The services that we provide would be coverage analysis and budget oversight, monitoring and education, research charge review, and also we're the team that activates your study within EPIC. Next slide. So now that you know who we are, we'll take a look about what it is that we do and why it is that we do what we do, which is research billing compliance. And that is our mission, a compliant billing program. A successful compliant billing program means decreased insurance denials, increase in reimbursements, expanded access for patients, and accurate, timely charge review. It also helps with mitigating the risks of noncompliance with federal regulations, financial penalties and exclusions that come along with noncompliance, and also making sure, importantly, that patients are receiving correct bills, that they're not getting billed incorrectly for services. Next slide. So I do want to highlight here at the start that we have important informed consent regulations that we just want to make sure you're aware of. This Code of Federal Regulations, as well as this HHS requirements for informed consent, are basically stating the same thing here, that any additional costs to the subject that they might incur as a result for participating in the research be clearly communicated to the patient in the informed consent. Next slide. Another important element that we want to highlight regarding CMS clinical trial policy is about the principal investigator and their responsibilities. So CMS ultimately identifies the principal investigator as the responsible party for making sure that their studies are billing in a compliant way. So we just wanted to highlight that and also give you the good news that that's exactly why we're here, to review your studies and make sure that they are meeting the requirements for CMS billing and research trials, and help to make sure that we are mitigating those risks of billing in a non-compliant manner. Next screen. So some of those risks include the False Claim Act violations. There's double dipping, which would be receiving payment from a sponsor and billing a third-party insurance for that same item or service. Inducement, such as incentives to stack patients in a study, and the kickback, the anti-kickback statute. Next slide. We also wanted to give some examples of the OIG financial penalties for noncompliance of those that we just covered. So this slide has a recent history of institutes and hospitals that have been found to be billing in a non-compliant manner and the penalties that they faced for that. Notably, this first one here at the beginning of this year, the Moffitt Cancer Center has to pay $19.5 million over that. for liability under the False Claim Act for a proper claim submitted to federal healthcare programs. So we are here to help make sure that the institution is protected, and the PIs are as well, by reviewing your studies with a critical eye to make sure that they are billing in a compliant manner. Next slide. So now that you know who we are and our mission, we'll talk a little bit more about the practicalities of how we function and how we interact with the IRB and OSP offices. And for that, I will hand you off to Scott.
All right. And so to look at how we interact with the IRB and OSP, we're also going to talk about uh, what we need in order to build your study in Epic. And so some of the components that we need to do that are a coverage analysis, an Epic build survey, and at least the principal investigator or co-investigator and one member of the study team to have the correct research Epic profile. Now, when the CRFO is reviewing a study in IRB, we tried to arrange it so that we're doing it in parallel with all these other processes that your research studies are going through. You know, as you're getting your IRB approval, you're usually also doing your draft contract and working toward finalizing that. And as you're doing these, that's where we want to be producing your draft coverage analysis and your budget review, uh, and also get your Epic build requests so that while that IRB approval process is going on, we can be producing your coverage analysis, we can be analyzing your budget, and our Epic applications team can also start building any of the required Epic builds if you need Willow medication records or Beacon treatment plans, so that process can also get started underway. And this is all with the goal to try and get your study activated in as timely a fashion as possible. You know, the studies that we need coverage analysis review and Epic build for are human research studies which utilize services or resources provided by the University of Illinois Hospital and Clinics. That can include our College of Medicine office clinics, our Mile Square Health Center, our Ryan White infectious disease clinics, both inpatient and outpatient services, and that can include, you know, clinical visits, professional services, medical supplies, labs, pharmacy, and imaging, whether for research or for standard of care. The studies that we generally do not select as needing a coverage analysis or Epic build are retrospective chart review studies, most behavioral health studies, and studies that are occurring at locations that are not currently built in Epic and aren't part of our UI Health hospital clinic space, and that aren't using any UI Health services, such as labs. When the CRFO does an ancillary review, what we're doing is we're looking in UIC research at new IRB submissions to see if a study might need a coverage analysis or might need to be built in Epic. If it's going to show up in your IRB submission as a CRFO ancillary review, and when we're doing that review, let's see, I think somebody might be unmuted at the moment. If all right, we we also review the language in the consents and contracts to look for inconsistency in subject cost language and in subject injury language. And I'm highlighting that here, and you'll hear Sarah highlight it later as well, because that is one area where we can often find inconsistencies, and those can really slow down your study activation if that language isn't consistent between the two. CRFO also completes ancillary reviews in UIC research, or rather, we do complete your ancillary review in UIC research when we receive back a signed draft coverage analysis from your team. And this is after we've sent you the draft coverage analysis for you to sign. And also when we get the Epic build survey back as well, if Epic build was required for a study. Now, when we do an ancillary review, we're going to usually put a comment like this in UIC research. We might say coverage analysis required, Epic build required. We might say coverage analysis not required, Epic build required. That middle one is mainly for studies where we don't anticipate seeing billable procedures that we're going to need to sort and bill to the sponsor or put a research modifier on. But those are studies usually that are gathering biological samples. And if you're gathering biological samples from our patients, we do want to build that study in Epic, and we do want you to link those patients to the study in Epic. Those studies usually won't require research billing review, but we do want to have those patients linked in Epic since we are gathering their samples. The last comment we might put would be coverage analysis not required, Epic build not required. And again, that's usually for those studies that are, retrospective chart reviews, not requiring any new procedures, or that may be taking place outside of the UI health footprint. When we've submitted an ancillary review in UIC research, it'll tend to look like this. If you're looking in your history, you might see submitted ancillary review, and if you click on that, it'll show you basically that CRFO put in the ancillary review. We, in this case, did not accept the study, and we didn't accept it because we determined it needed a coverage analysis and needs Epic build. Again, we're going to go in and we're going to flip that to yes once we get that signed draft coverage analysis back and once we get that Epic build survey submitted. Now, one thing for you to note is when you're submitting your project to UIC research, if you find that you're answering yes to questions 4 or 5 on the additional information part of the UIC research forms, you should probably go ahead and add a CRFO ancillary review. Question 4 is basically asking if you're using services provided by the University of Illinois Hospital and Clinics, that whole range of places I talked about a couple slides back. And question 5 is asking if this is a clinical trial. And usually if we've got a yes on either one of those, we usually need to conduct a coverage analysis review and possibly Epic build survey review. If you want to add a CRFO ancillary review in UIC research, we've put the steps basically here on one slide for you. You can click Manage Ancillary Reviews and then click the plus symbol. That'll give you an Add Ancillary Review like shown here on the right half of this screen. And in that case, then you would select the organization. You'd click on those 3 dots and start typing CRFO, and you'll get our organization in your drop-down list. For the review type, you would put coverage analysis, and then for is a response required, you would put yes. And this slide is here to show you basically the workflow for the offices that are going to be reviewing your submissions. In this case, we've got 3 rows of the offices your submission is going to work through. We've got the IRB, we have the CRFO here in the middle, and then we have the Office of Sponsored Projects down in the bottom row. And as we can see here, when your submission comes into IRB, if we add a CRFO ancillary review, then CRFO conducts a coverage analysis and if we find that there's a subject injury language problem or a cost language problem, then we'll notify OSP about that because they'll be working on your draft contract so that they can start trying to fix that problem. Otherwise, we will go ahead and produce the draft coverage analysis and send it out to you for signature. And we'll also have sent you that Epic build survey. And once we've got that signed draft coverage analysis back and that Epic build survey completed, then we will complete that ancillary review for you in IRB. And then that your project can move on to IRB approval. And then we move that finally there to our final reconciliation stage, which is where we compare the final protocol and the final contract again against our coverage analysis, just in case items changed during the review process, as can certainly sometimes happen, to make sure that everything is still consistent. And then we will issue that final coverage analysis and set up an Epic activation meeting with your team to activate your study in Epic. This next slide shows the same workflow just for an internally sponsored project, because obviously on an internally sponsored project, you're not going to have any involvement of OSP. And so the workflow here is a little bit simpler and doesn't go through quite as many steps. Things that can delay the CRFO's ability to complete an ancillary review will be if when we request items to do our coverage analysis, if we don't get a response. Similarly, if when we send out that Epic build request survey, we don't get a response, or if we notice that inconsistent language in the consent or contract regarding participant costs or subject injury. The Epic build request itself is just a REDCap survey on the OVCR website. REDCap is a data management program that Vanderbilt University created for managing clinical trial information. And this survey is a REDCap form, and it'll gather the essential study information like the title, the PI, the personnel, whether you're using investigational drugs or devices. And we use that content gathered on this survey to build the study in Epic. Everything we're asking for here is basically related to what we need to build in Epic in order to have your study running there, such as Willow drug plans or Beacon treatment plans. An Epic research administration record in it actually will tend to look like this screen, and this is where all that information you will have filled out on that REDCap form eventually ends up. We will copy it from there and then build your study here, with your study title, its IRB number, its National Clinical Trials number, NCT number, and a description as well of what the study is basically about. This is just showing the general information form of this page, but this research study admin record, as you can see by the left menu, has a lot of components to it. It'll list your users and providers and personnel, and then other items that we use when we're setting up the study to determine, whether this study is going to have patients going through research charge review or whether this would perhaps be exempt. This again is showing you a copy of the OVCR website where you can find the Epic Build Survey link. If you go to here and click Getting Your Research Study in Epic, then that link will take you to this page. And on this page, we have this REDCap link right down here, which if you click on it, will again take you to that Epic Build Survey form. And then I'm going to hand it back over to Sarah to talk some more about coverage analysis.
Thank you. So the way in which we review the study to make sure that it's billing a compliant way is through the coverage analysis, which is a reimbursement analysis for research. The independent review is independent review of the protocol to determine which clinical tests and procedures and interventions are billable to a third party and which ones are not. It helps to avoid those compliance pitfalls that we talked about earlier in the presentation. And our office will work with the study team to create that coverage analysis, especially if it's the first time that you're going through this process. We'll create that coverage analysis form for you that first time through and review it with you so that going forward for any future studies, you would be able to send that coverage analysis form over to us. Next screen. Our coverage analysis process is guided and dictated by the CMS National Coverage Determination 310.1. You can find this by Googling NCD 310.1, and here it describes the requirements for trials in order that are needed so that they can bill to insurance in a clinical trial, as well as what is considered a routine cost that would be billable to insurance. Next slide. And we'll take a closer look at both of those right now. What is required of a trial to be qualifying to bill insurance in a trial, and what would be considered routine costs. Next slide. So in order for a trial to qualify, to be qualifying and to be able to bill Medicare or Medicaid and insurance for routine costs, it has to meet these three base baseline requirements, that it's evaluating an item or service that falls within an already existing Medicare benefit category. The study has to have therapeutic intent, and it must be enrolling patients with a diagnosed disease, not just healthy participants. So it has to meet all three of these base requirements to be qualifying. Next slide. In addition to those three base requirements, it also has to meet these 7 characteristics of a trial, which would include the intent of the intervention to improve the health outcomes of the patient. That's supported by scientific and medical information. It doesn't unjustifiably duplicate existing studies. It has an appropriate research design for hypothesis, a credible sponsor, capable of executing the trial, and it's compliant with federal regulations related to human subject protections, and that it is conducted according to the appropriate standard of scientific integrity. Next slide. So if your study is funded by one of these government agencies, such as the NIH or CDC, or a center or cooperative group that is supported by one of those agencies, or the study has been reviewed by the FDA and provided an IND number, investigational new drug number, or been given an IND exemption, CMS will recognize that the study has already been reviewed for those 7 characteristics that we just looked at, and has been deemed that it meets those. So if it meets any one of these 4 criteria, CMS will deem it automatically qualifying, meaning that they accept that it was reviewed and that it meets those 7 characteristics that we just went over. If your study does not meet one of these 4 criteria, we have, in collaboration with the OVCR, created an internal review process to internally deem those studies as qualifying, so that we can, for internally funded studies, perhaps that are not using an investigational drug, there would still be a way to get that qualifying status and bill to insurance. If we look at the next slide, that can be done by filling out the principal investigator self-certification form, if you want to move to the next slide. And that form is here. So the principal investigator self-certification form, this would be filled out by the PI, and then reviewed by a representative of the OVCR who would review the study as well to make sure that it meets those 7 characteristics for a qualifying clinical trial. And if so, the form would be signed and we would have this internally deemed as qualifying. Next slide. For investigational device exemption trials, those investigational device trials, there is an extra requirement that would be needed in order to bill routine costs in the trial, and that would be that CMS has to approve the IDE trial. So to get that approval, you would send an attestation package with all of the documents listed here for CMS review, and if approved, they would then list that study as one of their approved IDE trials on the CMS website. Next slide. So for some examples, just a couple of examples of what would be considered a qualifying trial versus not, we have a phase 2 2-arm comparison trial testing the use of PET scans with and without radiopharmaceutical drugs. They're enrolling patients who have known metastases coming in for scans, and also those with no known metastases coming in for colon screening. So this trial would be qualifying because those PET scans and radiopharmaceuticals, those fall within a Medicare benefit category. They're enrolling patients with a diagnosed disease, not just healthy volunteers. They do have a cohort for that, but we've got our patients with metastases, and we would expect that the objectives for the trial clearly demonstrate the therapeutic intent behind the study design. For our non-qualifying trial, we have a phase 1 study of general population testing a new cholesterol-lowering medicine, enrolling only healthy volunteers. So right there, the fact that they're only enrolling healthy volunteers, that would mean that wouldn't be qualifying right off the bat. So it has to, again, meet all three of those baseline criteria in addition to the 7 characteristics. So this one would not meet the diagnosed disease requirement for patients, and so it would not be qualifying. Additionally, phase 1 studies are generally looking at safety and tolerability of a drug and not the efficacy, so that could be another reason, another disqualifying factor from this trial billing to insurance. Next slide. So now that we've looked at what requirements there are for a trial to bill to insurance, we'll look at what would be considered routine costs. So you've gotten your status as a qualifying trial. What services in the trial could you bill to insurance? So these are items or services that are needed for the reasonable and necessary care for the diagnosis or treatment of complications, including those related to the investigational item for the patient, and services that are available to Medicare beneficiaries, including outside of a clinical trial. So I do want to draw a distinction here between what would be considered standard of care and what is a eligible routine cost that could be billed in a clinical trial. So for patients with hearing loss, it would be standard of care to provide them with hearing aids. However, hearing aids are not, they do not fall within a Medicare benefit category. And so they would not be considered a routine cost that would be billable to insurance, even though it's standard of care. Because it's not something that's covered by Medicare, it wouldn't be considered a eligible routine cost. Next slide. Additional items that are defined as routine costs by CMS include those required for the provision of the investigational item or service, so the actual administration charges for that investigational drug, those administration charges would be considered a routine cost that are billable to insurance. And items that are needed for the monitoring or prevention of complications related to the investigational agent, so safety, laboratory testing, things like that. I do want to note that all other Medicare rules still do apply, so that's something else that we're looking at as we're reviewing your study. We are reviewing the national coverage determinations and local coverage determinations that Medicare has for specific services and items, any restrictions that they might have on how often or when that service or item can be performed and would be covered. So we're looking at all of those as well. Next slide. So when submitting that claim to insurance, these are the requirements of what's needed on the form, and that would include Q0 or Q1 modifier, Q0 for the investigational item or service itself, Q1 for items that are eligible routine costs that are billing to insurance. And the claim must also have the National Clinical Trial Number, the NCT number. So you can get that by registering your trial on clinicaltrials.gov. We do suggest that you do that as early in the process as possible so that activation of your trial is not held up at the end as we're waiting for the NCT number to be assigned. So get that NCT number early on in the process. Next slide. Now we'll take a look at non-covered research costs, investigational items. Next slide. So non-covered costs would be ones that are performed solely to satisfy data collection and analysis needs, services that are not being used in the direct clinical management of a patient. For example, monthly CT scans being done in a trial for a condition that would usually only require a single scan per year. Those additional scans would be considered research only, research specific, and would be have to be paid for by the study. Next slide. And lastly, if the sponsor has provided funding for an item or service in their budget or contract, you cannot bill insurance. This is that double dipping that we mentioned earlier, where we're receiving funding from a sponsor and then also getting paid for that same service again by billing to insurance. So if funding is provided in the contract, that is going to be billed to the sponsor. Next slide. So again, just to recap, for processing of the claims, if you've gotten your qualifying status as a trial, those claims going out to insurance must have the NCT number. the research modifiers, Q0, Q1, for the investigational device trials. In addition to those that I just mentioned, it also needs to have that CMS approval as a CMS-approved IDE study. Next slide. So to bring this back again, the principal investigator, since they're identified as the responsible party for ensuring compliant billing on the study, what we do is built into our process, we have our coverage analysis, we do a draft, send it for review, and then to make sure that the PI is attesting to its accuracy, we expect that it be reviewed and then signed and sent back to us, showing that it has been reviewed and we are in agreement over the coverage analysis. And then with the enrollment process by the principal investigator or sub-investigators, again, we just want to stress that it is the trial is clearly explained to the patient, including any financial responsibility the patient might have due to their involvement in the trial. Next slide. So a coverage analysis request can be made by sending an email to researchfinance@uic.edu. In that email, you would need to include the draft clinical trial agreement or award. And again, I want to stress this would be draft. At this point in the process, as was shown a little bit earlier, how we're working in parallel with OSP. We wouldn't expect to have a finalized contract yet, since our go-ahead for getting signatures on that agreement is needed before that can happen. So you'd be sending us the current draft version of the clinical trial agreement or award, along with an itemized budget, which includes all of the sponsor-paid services and what they're paying for each service. The coverage analysis template, which you can download from the OVCR website. And we ask that you do include the study's IRB number in the email subject line so that we can easily identify which study it is. In addition to those, you can feel free to include any reference material that you feel might help to justify whether procedures can bill to insurance or not, such as clinical practice guidelines. Next slide. So if you go to the OVCR website and click on this area here, Research Study Billing Compliance, it will take you to the next page, where you can find information about the coverage analysis and CRFO budget review process, our forms, and answer any other questions you have here. You can, of course, email the Research Finance inbox if you have questions for us about the process. Next slide. So our coverage analysis form, this is showing us a portion of that. It's an Excel file that consists of two main tabs. We have our study information tab, we're looking at a portion of that now, and the billing grid tab, which we'll look at in a moment. On the study information tab, it'll have general information about the study, such as the department, PI name, protocol. Also very critical is that the protocol version and ICF versions be listed on the coverage analysis. That way we're ensuring that the versions that are being reviewed to create the coverage analysis are the same ones that are being used once the study is open and enrolling patients. It'll also have some additional information like the NCT number, information about the sponsor, etc. Next slide. Also on the study information page is this section here, and this goes over the qualifying clinical trial analysis. So it's going to ask for the, identifying the Medicare benefit category, if there's therapeutic intent, the diagnosed disease of the patients being enrolled, and then that fourth box there has to do with being automatically deemed, considered automatically qualifying by meeting any one of those four criteria, such as funding by a NIH, CDC, et cetera, or having been reviewed by the FDA. And again, if your study does not meet one of those four automatically deemed criteria, you can always pursue internally deeming your study through submitting the PI certification form. So if all four of those are a yes, then that last one, your study would be considered qualifying and eligible. Routine costs could be billed to insurance. If any one of these would be no, then the study would not be qualifying, and all services related to the study would have to be paid for by the sponsor. Next slide. This is an example of the second tab on the coverage analysis form, the billing grid. And here it will list out every study time point along the top, as well as every service and item performed as a part of the study on the left-hand side. And then within the grid itself, it will indicate when exactly each of those services or items takes place within the study, as well as how those services are expected to be billed. So an E, for example, is considered effort, so it's something that wouldn't generate a billable service. It's not associated with a CPT code, or it's perhaps something that bundles into a different service, so it's not separately billable. S would be for items that are being paid for by the sponsor, and we use that N designation for any services that we have confirmed can be considered routine service and is billing to insurance. Next slide. Our coverage analysis also includes this key that you can see here, where it breaks down each of the designations and the colors and what they mean, as well as a reminder of the Q1 and Q0 modifiers and which services those would need to be attached to. Next slide. So just as a reminder, routine costs that are required by the protocol, required in the protocol, do need the Q1 and Q0 modifiers. They're going to have a Z00.6 diagnosis code on the form, as well as that NCT number and condition code 30. That'll all be on a claim that is going out to insurance. And if your interventional clinical trial has not been registered with clinicaltrials.gov, it will delay activation. So again, you want to do that as early on in the process as you can to get that NCT number. Next slide. So for the steps to get your coverage analysis and CRFO budget review would be, number one, submitting your study to UIC research and getting that IRB number assigned to you. Once that has officially been submitted to, for UIC IRB review, you would then submit the completed coverage analysis form, the itemized budget and draft contractual agreement to Research Finance at uic.edu. And then 3, you would receive the draft coverage analysis and budget review back from the CRFO within 15 business days, and then you would just need to review that and send it back with signature to our office here. Next slide. It's important to note that we will not begin work on IRB applications that are still in pre-submission status. So before submitting to us, that study does have to officially be submitted to UIC IRB within UIC Research. Next slide. This shows the coverage analysis signature process. So we create a coverage analysis signature page, which is basically a PDF version of that study information page that you saw on the Excel form. And at the bottom, there's a space where it can be electronically signed by the PI or PI designee. We do have instructions on how to sign this form electronically without locking it, which is how we ask for signature to be given so that the Excel file remains attached for version integrity. And also we'll be able to flip that to final once your study is ready for the final coverage analysis. Next slide. Some of the internal terms that you might see referenced by us as we're working on the coverage analysis would be CA working draft. So that indicates that work is underway, but we have not yet completed our review of the coverage analysis form. CA draft, that is when our review is complete and it has been sent to the study team for signature. CA exempt is when we've conducted a coverage analysis and determined that there are no sponsor paid items or billable services that require research codes and modifiers to insurance. So there are no billing implications for the study. An example would be a study where they're collecting biospecimen from a patient, but there's no billable services occurring with the study. And then CA final, so this is after we have IRB approval and we have a fully executed contractual agreement That draft coverage analysis gets flipped to final, and you have your final CA. Next slide. And now we will do CRFO budget review, and I will hand this back over to Scott.
All right. Thank you, Sarah. And as we noted before on that slide showing our parallel processes, when you submit your information for coverage analysis, that's when we also start your CRFO budget review. And our budget review is mainly done to confirm that you're budgeting with our current research fee schedule prices. We're not here to approve your budget, but we are here to warn you if the costs that you're going to get back from the hospital are higher than what your sponsor is agreeing to pay, so that you can determine whether you want to go renegotiate with that sponsor or try to make up that deficit out of department funds. But that's the main thing we want to do with the budget review is give you a realistic estimate of what your costs will be. Let me get it to go to the next slide again. I also wanted to talk about our research discount rates. These are the discount rates that you're all familiar with and that are in effect for current studies that are running, and in which we have recently revised. Our old discount rate model, as you can see here, we gave a 50% off the industry discount, a 60% off for a foundation. For a federal or internal study, we used our DHHS negotiated rate, which varies by cost center, and that's based on our Medicare cost report that we have to file each year, which basically lets us know what our actual cost for a procedure was. It's sort of our minimum cost to deliver that procedure. And also our old discount model, we can see for professional fees or PB, sorry, I scrolled where I didn't want it to go. Our old PB discount just was a flat 50% off, and it didn't matter what kind of sponsor you had. And we've been looking at this, and we have a new research fee schedule we have put into effect for studies activated after September 1st. And this is very much to base our research discount model more around our minimum cost and around what other institutions, other academic medical centers around the country tend to do. So you'll see here this new research discount model basically just divides studies into two types: for-profit, which would be industry and pharma-funded research, and nonprofit. So whether it was federal, internally funded, or a foundation, that would all be part of our nonprofit group now. And those nonprofit groups, the hospital technical fees or facility fees, will again bill at that DHHS negotiated rate. There isn't any change there for a federal or internal study. There would be for a new foundation study. The bigger change there for our nonprofit sponsors is that the professional fee would now be would be our Medicare rate for that service. And if we don't have a corresponding Medicare rate, then we take 80% off the fee schedule price. And our for-profit model is now just basically an increase in the price over our nonprofit rates. So for our for-profit, we're just adding an extra 50% on top of our nonprofit rates. And we've found that this again corresponds to how we've noted most of our other academic medical centers are doing this, and this also I think it's much more defensible because the hospital is basically making sure that we're meeting our minimum cost and then charging industry a little bit more. Our other discount model, with the way it was based, could sometimes provide pricing that we didn't find to be as sensible. When you get a CRFO budget review from us, it'll come on a form like this. There's a header part of this that'll list the PI and whether it's a for-profit or nonprofit study and the study title. But basically, the sheet that you're going to get is a few columns here in gray, which are showing you the description of the procedure, what we anticipate the CPT coding for the procedure will likely be, what our regular prices are for it. And then in our blue-headed columns, we'll show you both the technical facility research price and the professional PB research price and the total of what that is. We'll compare that to your sponsor procedure rate price in that sort of dark green column header. And then we'll basically do some math on the anticipated quantity and try and let you know whether you're looking at a surplus or a deficit on meeting your cost on that individual item. We do advise you to budget for increases in our fee schedule rates. We usually advise for a multi-year study that you budget for a 5% increase each year. This slide that I'm showing you now shows our research fee schedule Excel file, which we are happy to send out to you. You can email us at researchfinance@uic.edu to request a copy, and we'll add you to our distribution list. We'll send this out usually twice a year now. It'll be after the beginning of each calendar year when our Medicare rates change, because that obviously will affect our professional fees on here. And we'll also send it out after July 1st each year when our whole fee schedules rates change, because that's when the hospital increases its prices each year at on July 1st. This file is obviously for internal use only. We don't want you to send this straight off to your sponsor. That would have all of our research prices, and that wouldn't necessarily help you in your negotiations with them. But again, if you'd like a copy of this, please email us at Research Finance and we will send it out to you. And if you have questions about using it, although we do have a lot of instructions on the cover sheet, we're also obviously always happy to answer those questions. The next topic we wanted to talk on is requesting EPIC research training, because this is another item that can slow us up on getting your study activated. If none of your study personnel have actually the right EPIC profile to do their study activities, we won't be able to turn that study on in EPIC yet. And to request EPIC research training, you're going to need to ask your access requester to put in that request for you. They'll do it through this IS training and resources. They'll put in what's called an ARF, an access request form. Usually your department administrator officer can tell you who your access requester is. If for some reason you have trouble with that, you can go here onto the website and look it up under the access requesters list by entering your department. I would still say your department administrator officer is a better source of truth, because these entries can sometimes be a little out of date. But if you can't find the information any other way, this is a place to get it. Then when they're putting in that access request for you, one thing that they're going to need to know is what role to request for you. And so we wanted to talk a little bit about EPIC research roles so that you can make sure to tell them the right one. You'll see here on this list, as I start typing EPIC role, I start typing the word research, I get a whole bunch of roles that start with research. And really the ones, if you're going to be associating patients, linking patients to a study and possibly reviewing charges for them, the roles that you're going to want are those research coordinator, investigator, credentialed or non-credentialed roles, or possibly with scheduling as well. Some of the other roles shown here aren't going to give you the abilities you need, and we'll take a look at some of these other roles right here. The EPIC research coordinator role, when your access requester selects that, they'll get this description of the powers that this role has. As we can see, this one allows you to enroll and associate a patient to the study and perform research billing review, and also to coordinate and manage study monitor access. We can look at the same description for the non-credentialed role. This one is very much the same. The difference here is if we look at the order description, we can see for orders, this role can append procedure and medication orders, but obviously can't sign them. That'll still need to be done by your PI or the person with the proper credentials to sign an order. We can also look at the research coordinator investigator role with scheduling a non-credentialed. This one is another variant of that, but allows you to create MRN numbers for new patients, and again might be a role that you might need someone on your study team. There are some variants of this role specific to oncology, which just simply have the word oncology in front of the role. Otherwise, the descriptions are the same. So if you were in cancer center or and working on one of our cancer center studies, these are the roles that you would want to be selected for your team. Uh, but the thing when you send this to your access requester that you don't want them to pick is you don't want them to pick research billing specialist or research billing supervisor. Those are our people in the clinical research finance office who do the initial review of research charges. And you may not want them to select some of the roles that only have data viewing capabilities, like research chart reviewer or research data coordinator. These roles, we might see on a study that might be CA exempt, where people are only taking information from the chart. But again, someone with this kind of role could not link a patient to a study and couldn't perform charge review. Now, when you do have the correct role, uh, then you will get access to the Research Coordinator My Studies dashboard, which basically looks like this. It can be customized. So if you've got one of these, yours may not look quite the same as this anymore. But we can see on the right hand of the screen over here, this total balance needing research review coordinator and the arrow underneath it. This is where a coordinator would click to run their report to see if any of their patients have charges that need research charge review. And one thing I want to mention when we talk about research charge review is if your study is going to have sponsor paid charges or charges that require a Q1 modifier, when we hold the charges for that patient, we are going to hold all of their charges from the time that you consented them until the time they're in a status that doesn't require charge review, such as off study or possibly being in follow-up. Uh, and the reason we do that is that's really the only way to make sure we cash your research charges and don't misbill them. So when you're doing research charge review, we're routinely reviewing encounters that are not related to your study. If someone comes in for a broken arm, we're going to have to review that encounter. We'll say it's not part of your study, and your coordinator will confirm that. But it's something I want to always emphasize to study teams that, in order to make sure that we don't misbill your patients, we do have to hold all of their charges. And one other thing I wanted to mention, because we have seen a few instances, is right now our Epic system lets you select a patient as eligible, as someone that you want to consider for your study. And that's a little bit of Epic language, not necessarily always lining up with how the research community thinks of things, because sometimes if we think of a patient as eligible for a study, that might mean we've already performed screening tests on them and found they met all that screening criteria. But the EPIC eligible status, as it exists right now, just is for if you're considering a patient for a study to be used before you consent them. That eligible status does not hold those patient charges. So if you link a patient and put them in eligible and are hoping to not have their charges go out to their insurance, you need to enter that consented status or update their status to consented first. That's when we will start reviewing their charges, as soon as you've noted in EPIC that patient is consented. Uh, then when we're reviewing charges in EPIC, it'll generally look like this. This is just from our training environment. But we can see that charges come through, and basically they've got some square boxes over here on the side that we can check in if we find we need to move something to bill a different direction. This current screen is showing you an encounter where we reviewed the study and compared it to the coverage analysis and compared it to the participant tracker or encore calendar, wherever the service dates for when these patients came in is being recorded. And we noted that these items needed to bill to insurance with routine modifiers, where it says research modifier there. It says routine. That would be that Q1 modifier that Sarah showed you a few other places. On the same encounter, the patient had an ECG, and by looking at the coverage analysis, we determined that was not part of this study. So that one would go out to their insurance without codes. These EPIC screens will show you the office visit with the technical or facility charges with a pink header, and the physician or professional charges with a blue header, like the one down at the bottom of the screen where we're not quite seeing the charge detail. Then lastly, we wanted to talk about some of research policies that govern research here at UI Health. And these are both on the hospital's intranet, but because a lot of our study teams may not yet have access to the hospital intranet, we've also hosted them on the OVCR website, the URL showing here. And we have 5 policies governing research that if you're new to research here at UIC, I really encourage you to go through and read each of these. They're not overly long. They're maybe 3 to 4 pages each, but they go over, what our expectations are for research charge review, for billing compliance, for research activation. And that's an important one for us because often study teams, when you get that IRB approval letter, you've obviously been waiting a while at that point. You're anxious to get enrolling your subjects. But if this study did require a coverage analysis and did require being built in Epic, we need you to wait for that Epic activation meeting with the CRFO before you start enrolling, because until we've had that meeting and have turned your study on in Epic, you won't be able to link those patients to your study. So I did want to emphasize that if it is a study that is going to require research charge review, you don't want to start enrolling until we've activated your study in Epic, when you can link the patients correctly. Also, our medical documentation policy will go over, what information we expect to be in the medical record. There's also some tip sheets as well about writing notes for research patients that are available in Epic, and how you can use templates to do that and simplify your task. But items that we routinely expect to see in the medical record for research patients are documentation of the informed consent process. We expect to see the patient's signed consent scanned and uploaded into Epic. And again, there are additional tip sheets that we can provide you on ways to get those ways to get that to HIM so that those get scanned and uploaded correctly. And that might not seem that important to you, but frankly, those consents uploaded in Epic are something that we use in research billing all the time, because we'll verify that our consent version you have uploaded in Epic matches our consent version our coverage analysis is based on. And this sometimes makes us or helps us find when a study has actually had an amendment that we weren't aware of yet. And helps us then contact the study so that we can get that coverage analysis revised to match the current amendment, so that, again, we make sure we bill your patients correctly. If we're working off a coverage analysis that's 2 or 3 or 4 protocol versions behind what you're doing with your study, you might have charges on your more current protocol that your old coverage analysis wouldn't be aware of. So when your study does go through amendments, we do ask you to fill out an amendment form for us and let us know. And yet another way that we will sometimes discover that is, again, when we're looking at that consent version for your patients in Epic. And this, again, helps us protect your patients from being misbilled and helps us protect your PI from misbilling patients. So this, again, is something that we're trying to do to make sure that your study runs correctly. And our last policy there, allowance of hospital resources for human subject research, is our newest one, and that goes over what our payment expectations of you are. When your charges have gone through research charge review, then on the 5th of each month, those research accounts are going to close, and we're going to then send out a research statement to your team in the middle of the month, and then we're going to expect payment on that statement within the next 30 days, and all that is detailed in that last policy, that LD 3.17. And this is our current CRFO team, and Linda Yancey is our director, and Sarah and I are our 2 assistant directors, and we have Elizabeth and Winston working with Sarah on the creation of coverage analyses and budget reviews. We have Charnel and Melita doing research charge review of research charges in Epic, and Corey Ringhausen is helping build all of our IT systems, our REDCap participant trackers, and our REDCap database that helps us manage all your information. And that is our presentation, and now we can certainly take any questions that you've got. Let's see. I see a couple things here in the chat. Okay, somebody was having trouble seeing the screen, but so yeah, if anybody has any questions and they want to unmute themselves or type it in the chat, please feel free.
Okay. I don't see any questions.
Nope.
Thank you, Scott and Sarah, for the presentation and everyone for attending today. And if you have any questions, you can reach out to Scott and Sarah. We will be sharing this presentation with you after this in the CCTS training website, and their email IDs are also there. So we look forward to seeing you in our next best practice hour.
All
Thank
right.
you.
Thank you.